Hi, my name is Suji Beg. I am one of the third year OBGYN residents at Omiko at Oklahoma State, and my QI project is over rate of cesarean delivery among BMI 40 plus undergoing induction of labor at Oklahoma State University Medical Center. So in 2021 to 2022, about 42% of women ages 18 to 44 in Oklahoma were reported to have BMI over 30. And it is now considered one of the most commonly occurring risk factors in obstetric practice and is encountered very frequently in our patient population. And I initially wanted to look into ways to improve the induction of labor process for this patient population because not only do they have a more difficult induction of labor, they are at increased risk of congenital anomalies, gestational diabetes, preeclampsia, and so forth. So I looked into the past 2 years of data of induction of labor patients that happened at Oklahoma State University Medical Center. And inclusion criteria included they had to be term, so greater than 37 weeks of gestational age, singleton pregnancy, and cephalic pregnancies, and they were undergoing either elective induction of labor or medical induction of labor. They were divided into different BMI groups, and the rate of vaginal delivery for these BMI groups 20 to 29, 30 to 35, 35 to 40, as evidenced by the pie chart, was very good. It was 80%, if not over, but specifically for the group with a BMI of 40 plus, had a vaginal delivery rate of only 56% and a significantly increased cesarean delivery rate of 44%. So then I looked into the different indications of cesarean deliveries for these different groups. So if you look at the BMI 20 to 29 and 30 to 39 group, the most common reason for cesarean delivery was for non-reassuring fetal heart tones. So it was more so that the fetus was not tolerating labor and not for maternal reasons. But if you look at the BMI 40 plus group, then the most common reason for cesarean delivery in this group was actually failure to progress. So, for whatever reason, their cervix just did not even reach to the point where they could start pushing. Their induction just did not progress, and eventually they had to call a C-section delivery. Of this group, the mean time of induction of labor until decision to cesarean delivery was 35 hours with a standard deviation of 10. And I also looked at the different routes of medication administration for these inductions. So 66% of these inductions used oral misoprostol, 22% used vaginal misoprostol, and 22% used Cervidil. And of the BMI 40 group that made it to complete cervical dilation, I noticed that all of them had used vaginal misoprostol. And although the sample size was too small for statistical significance, I think this could be a good starting point for further studying the effects of these medications and routes. And so I believe this QI study highlights a statistically significant association between higher maternal BMI and increased rates of cesarean delivery following labor induction. And the extended induction time, as well as the increased rate of failure to progress with possibility of varied efficacy of MISO, I believe underscores the complexity of managing obese obstetrics patients. And we could consider a more robust preconception counseling with even just a little bit of weight reduction and continuing to allow for longer first stage of labor as recommended by ACOG, which we are already doing. And further research into the efficacy of oral versus vaginal misoprostol, especially for this group of BMI over 40, given the possibility of improved efficacy of vaginal misoprostol. And most importantly, when we are counseling these patients in the prenatal setting in clinic, I think it's important that we tell them what to expect, and they should expect a longer induction time And I think there is definitely more room for improvement in this project.